Dr. Michelle Clayton. I'm happy to be here today to talk to you about take-home, naloxone, and harm reduction strategies. I'm an addiction medicine consultant at True North Medical, as well as St. Michael's Hospital, and I also work as an emergency physician at St. Michael's Hospital. I have nothing to disclose today. The learning objectives, as outlined by the OPA, are first to understand the harms associated with opioid use disorder. Second, to discuss the principle of harm reduction overall. I'll then go through a few of the harm reduction strategies that we use here in Canada, including naloxone emergency kits, needle and syringe programs, also known as needle exchange programs, and safe injection sites. The one in Canada is in Vancouver. I'll then talk as I go through this about the benefits, successes, and barriers of each of these different harm reduction strategies. In terms of the harms associated with opioid use disorder, a lot of them are pretty obvious. So we've been seeing a lot in the media right now about the number of opioid overdoses in Canada. And the reason we're seeing this is mostly because of the fentanyl that's been contaminating our heroin. And a lot of people have been dying as a result of this. We then see a lot of skin and soft tissue infections, so cellulitis or abscesses as a result of people using dirty needles. And then endocarditis, sepsis, epidural abscesses are actually quite significant and serious medical complications seen with IV drug use, and these patients can end up in the ICU. HIV, hepatitis B, and hepatitis C are quite common amongst our population. We do see a lot of crime. And then, of course, the side effects of chronic opioid use. So these are the side effects that we're very familiar with, such as constipation, sedation, diaphoresis, and problems with endocrine function. So besides crime, these are the medical harms of opioid use disorders. But don't forget, there's also psychological and psychosocial harms. So the principle of harm reduction is to decrease the health and social economic consequences of addiction-related problems. This mostly focuses on the medical complications and does not exclude abstinence as a goal. This provides people who use drugs with more pragmatic choices when they're not ready to reduce or stop their drug use. One of the main criticisms of harm reduction is that if a behavior can be partaken of safely, there may be an increase in that behavior. So in other words, if we allow people choices on how to use drugs more safely and reduce the harms associated with these drugs, it's possible that they might continue to use drugs, might use more drugs, and might not be motivated to reduce their drug use. I'm going to go through a case study to illustrate these points. So Jake is a real patient, although I've changed his name, and this is not his photograph. He's a 34-year-old male who came into my clinic with an opioid use disorder. He was prescribed Percocet about 5 years ago by a well-meaning physician for knee pain and escalated to IV heroin use over time. He has past medical history of cellulitis and abscesses associated with his use, and he has engaged in treatment before at the Fred Victor Day program, which is a program here in Toronto, however, is not attending any treatment programs right now. So Jake comes into the emergency department. This is a photograph of the ambulance bay at St. Mike's. The chief complaint on the chart is opioid overdose, and the paramedics are actually supporting his respirations by a bag valve mask, so they're breathing for him. The emergency physician gives him 2 doses of Narcan at 0.4 milligrams IV, and Jake wakes up because this is the appropriate treatment. Narcan is an opioid antagonist, and he is then agitated with a resp rate of 14 and a saturation picks up to 97%. 2 hours later, he's awake and he's ambulatory and he's ready to leave the department. The emerg doc engages him in a discussion on his heroin use, and he does admit to using heroin. He's not sure why he overdosed at this point. Maybe it's the fentanyl that's contaminating the heroin in Toronto right now, and he's not interested in treatment. So the question is, what can we do for him? I want to take a minute to talk about some of the statistics associated with opioid overdose. So this graph is a bar chart showing the total number of U.S. overdose deaths involving heroin from 2001 to 2014. It's overlaid by a line graph showing the number of deaths by females versus number of deaths by males. And we can see there is a difference, so more men are dying than females. From 2001 to 2014, there was a 6-fold increase in the total number of deaths. So this is a real problem, and this is great data right out of the National Institute on Drug Abuse. When we look at prescription opioid pain relievers, we see a very similar trend when we compare it to heroin. So this figure is another bar chart showing the total number of U.S. overdose deaths involving opioid pain relievers from 2001 to 2014, again overlaid by a line graph showing the number of deaths by females and males. So from 2001 to 2014, there was a 3.4-fold increase in the total number of deaths from prescription opioid pain relievers. So this isn't just a problem related to heroin, it's also related to the prescription opioid pain relievers that us physicians are prescribing and flooding the market. So to bring this back home, we're seeing very similar data in Canada. Between 2009 and 2014, there were 655 fentanyl-related deaths, and this number is increasing, especially over the past few months. In Ontario, a study came out in 2014 by Gomes et al. She's a researcher who works at St. Mike's. The rate of opioid-related mortality increased by 242% between 1991 and 2010, and this correlates with increased number of prescription opioids by physicians. In Toronto, again, this data is quite old now, coming out of 2009, but the coroner stated that in 2009 there were 74 overdose deaths in Toronto, and I'm sure these numbers are much higher in 2015. When we look more closely at the Canadian data, there was a study that came out in 2014 in Addiction Journal, and the data was reported by CBC News that summer. So this study showed that OxyContin and other opioids are tied to 1 in 8 deaths in young adults, and that was quite a surprising number. And again, when we look at the data, we see that the prescriptions for high-dose opioids are on the rise, and this correlates with the number of deaths.
So 2014 was the year of OxyContin. 2016 is the year of bootleg fentanyl. What we've seen in Ontario now is a rise in deaths related to fentanyl either being substituted for heroin or being mixed in with heroin and other opiates. People use the substance thinking that they're using the same drug they've used every single time, and they end up overdosing because the potency is much higher. Now we're seeing an emergence of carfentanil in Ontario, which is even more potent. So what do we do about this? I hope by now you've all heard about take-home naloxone. Naloxone is an opioid antagonist, so it is an antidote to opioid overdose. The idea behind this is that we know that patients who use opiates use together. If person A overdoses on their opiates, person B can take out their Naloxone Kit and inject this life-saving medication into that patient's muscle and save a life. Since this summer, all Ontario pharmacies have been eligible to dispense Naloxone emergency kits free of charge to eligible patients, and these claims can be submitted through the health network system so that you are compensated for this important work that you do. This is what my Naloxone Kit looks like, and they come in various forms. It's about the size of a sunglasses case. On the inside are 2 doses of naloxone, so 0.4 milligrams with a safety cap on top, alcohol swabs, a couple syringes, as well as a protective barrier for rescue breathing.
Naloxone distribution is not new. Naloxone has been distributed in England and Germany since the mid-1990s. In Turin, Italy, it is available over the counter, and in Scotland, it is prescribed by qualified nurses and pharmacists. There are over 200 programs in the United States that distribute upwards of 40,000 vials per year, and there's been over 10,000 uses of naloxone since 1996. In Canada, our first program started in Edmonton at the Edmonton Street Outreach Program, and our program here in Toronto started in 2011. Toronto Public Health has distributed over 3,000 kits and reports over 350 uses of the kits. Programs are expanding across Canada. In 2012, Ottawa Public Health and the BC CDC started their own programs, and Fraser Health in BC has now started a program to distribute naloxone through their emergency departments across the province. There are a few emergency departments in Ontario who are going to be starting to distribute naloxone as well within the next year. There are a lot of barriers to naloxone distribution. First and foremost, the stigma is huge, and I think this overshadows why harm reduction isn't in every single community. The kits that we have right now are quite cumbersome, and the research is somewhat lacking. So what is your role? So pharmacies are an ideal point of access for naloxone distribution. We know that 56.1% of people who died of an overdose filled a prescription for opioids in the last month before they died. I'm going to bring it back to Jake. So Jake comes into the emergency department a second time. As you remember, the first time he overdosed, and we told him about the Naloxone Kits, and now he's back. He's come back because he has an abscess on his left forearm requiring an incision and drainage, and he's not interested in treatment at this time again. He is, however, open to discussion about some more safe using practices. So he has the kit. What else can we do for him? So this leads into a discussion about bloodborne diseases and the infections that people can get from using dirty needles. So we know that the rates of HIV, hepatitis C, and hepatitis B are quite high. So these data are for needle stick injuries, transmission rates for needle stick injuries. So if somebody is stuck with a needle that is positive for HIV, they have a 0.3 chance of getting HIV. If they're stuck with a needle for hepatitis C, there's a 3% chance of them getting hepatitis C. And if they're stuck with a needle for hepatitis B, there's a 30% chance of them getting hepatitis B. So 19% of those with HIV use IV drugs, and you can interpret this another way, saying that 19% of the people who have HIV got it from using IV drugs, although that might be a generalization. We know that hepatitis C is the most prevalent among IV drug users, more than any other group, and in fact 66% of all IV drug users and 28.5% of former IV drug users are antibody positive for hepatitis C, so they have active or previous infection. The incidence is also quite high, so 20% for each year of IV drug use. Interestingly, the rate of hepatitis B is decreasing, even though it is the most transmittable, and that's because of vaccinations. So how do we prevent this? Well, we can give people clean needles and teach them how to clean their needles properly. So I thought this article was quite interesting. It's from the Toronto Star in 1988. And this was the first article published on Toronto doctors giving quote-unquote addicts clean needles. I encourage you to read this on your own time. It's quite interesting. There's some quotes from Jack Layden, who was the chairman of the Toronto Board of Health at that time, as well as Metro Police Chief Jack Marks. His quote, I'm just going to read it, the second paragraph here. So, AIDS is a dreadful, terrifying, and terrible disease. On one hand, I don't want to promote drug abuse, but on the other, I must endorse anything that can be done to prevent the spread of the virus. So this is really where this all started in Toronto. So the first needle and syringe programs officially opened in Toronto and Vancouver in the late 1980s, and started with a few docs giving out clean needles. In Canada, there's only over 200 needle and syringe programs, and this is only their primary site, so there's multiple satellite sites of these different programs. It is not an offense under the criminal code to distribute needles to prevent the spread of HIV, and this is a really big concern for organizations wishing to give out these needles. There might be a worry that if they're giving out needles, they could be prosecuted for promoting drug use. Here's a legislative reference from the Criminal Code and the Food and Drugs Acts. You can read it on your own time and go through it if you like, basically outlining that it is not illegal to distribute needles for the purpose of reducing transmittable diseases. So when we talk about needle and syringe programs, we're talking about equipment and everything else that comes with the equipment. So the equipment that comes in one of these bundles are clean needles, syringes, sterile water, alcohol swabs, tourniquets, filters, acidifiers, and cookers. And all these components will help people use more safely. This is a picture of a needle and syringe kit. This is from the Globe and Mail. So you can see that there is the cooker right in the middle. It's a metal container. On the right-hand side is a clean syringe and some sterile water. So people put their drugs of abuse in the cooker. They put the water into the cooker with the drugs. They use the matches to cook the drugs and then draw them up using the syringe. Most of the kits now will come also with a cotton filter. So it's not just about the equipment, it's also about the harm reduction bundle. So in most cases, when somebody picks up a needle, they're going to be interacting with some and they can get education on safe injecting practices. They can get counseling or social services. They can get treatment or referrals into a treatment program and safe syringe disposal. This is going to vary depending on where the program is. So for example, at St. Mike's Hospital in Toronto where I work, we have a needle exchange program. However, it is simply a bin in our waiting room in the corner where people can pick up a package of needles and all this equipment in a black bag and dispose of their needles. They don't actually have to register or talk to anybody. But if they would go to Toronto Public Health, they could actually engage in a conversation and get some of these services that are available there. So this is going to vary. The evidence for needle and syringe programs is quite robust. So we know that it reduces the risk of HIV. It decreases needle sharing amongst drug users. It decreases the use of dirty needles. And we also know the number of needles turned in is greater than the number handed out. So we're getting needles that people get from other sources. We know that these programs increase involvement in treatment because they can access the services that I talked about on the previous slide. And we know that the programs are cost effective. The needles cost pennies. Treatment of endocarditis or abscesses or HIV or hepatitis C, those cost a lot of money. So the cost of a few needles pales in comparison to the cost of the harms associated with IV drug use that we can prevent. We know that it does not increase crime. They do not increase the number of used syringes discarded improperly in public spaces, and it does not encourage drug use. So the barriers for needle and syringe programs, a lot of these are probably quite obvious. In some countries, there actually is criminalization of possession of drugs or injecting equipment. So luckily, we don't have this problem in Canada, where people just carrying drug paraphernalia are going to be arrested. However, this is a real possibility in many other countries, especially in Europe and the Middle East. There are legal age restrictions in some cases for accessing needle and syringe programs. Again, luckily not within Canada, but this is a big problem if you have a 16-year-old who's injecting IV heroin and wants to use clean needles. There are certain countries where they wouldn't be able to access the program until they were 18 years old. There's a lot of stigma and disapproval from the community and argue that this should probably be at the top of the list. And then, of course, funding and physical and geographical barriers. So who's going to pay for it? And if somebody lives out in the bush, how are they going to get clean needles? So what is your role? So again, you play a very important public health role here. Pharmacy sales are legal, and that is encouraged by the Ontario College of Pharmacists because it is in the best interest of the patient. That being said, you must exercise your own individual professional discretion in each patient. There are reports of Canadian pharmacists refusing to sell syringes to people who use drugs. So this is an opportunity to think about whether or not this is a program that you would like to engage in. I'm going to move away now from the needle exchange programs and talk about another patient named Lily. So this is a real patient again. So Lily is in her mid-40s. She's a former healthcare worker and lives with fetal alcohol effect and a psychiatric illness. She's been injecting drugs for about Lily's really lucky. She lives in Vancouver, and she was able to access Insight. So Lily started to visit Insight so she could use drugs more safely. The staff at Insight became her support network and connected her with treatment, and over the last year, Lily has not used drugs for 9 out of 12 months. So Insight, for those of you who are not familiar with, is a supervised injection site in downtown Vancouver. On the left-hand side is a picture of an individual standing outside their front door. Now on the right-hand side at the top is a picture of the materials they provide free of charge for drug users. On the bottom on the right-hand side is a picture of Insight's interior, and what you can see there are 13 injection booths where people can use drugs safely. They do not obtain their drugs from Insight, but they can bring their own drugs and inject there in a safe environment. So Insight opened in 2013, and it's the only supervised injection site in North America. There are 13 injection booths, and the patients who come in there also have access to nurses, addiction counselors, mental health workers, and peer support workers. They provide overdose treatment, wound care, immunizations, and connect these patients with family physicians. In addition, they connect clients with community resources and get them enrolled in treatment programs. Insight reports approximately 800 visits per day, and there was a lot of concern at first that they might attract new drug users, so people who have never injected heroin before, for example, and want to come and inject it somewhere safe. However, there's been a lot of data showing that they actually attract drug users who have high risk of health problems and overdose, hepatitis C, and HIV, and that a lot of these people have been using substances for years. So they are seeing some young people, but in general, the people that they're seeing have been using drugs for upwards of 5, 10, 15 years. There's been no overdose deaths at Insight, and that's because they have nurses and staff on hand with naloxone to use it should somebody overuse their opioids. Insight has done a lot of research into the benefits of their program. So there's been studies published that show that they do prevent overdose deaths, as I mentioned. It facilitates entry into detox, and it improves public order, reduces public needle litter. We know that ever since Insight was started, clients are 70% less likely to share syringes, and there's been a lower rate of skin infections reported in that general area. So going back to Lily, I'm going to read a direct quote off the Insight website to show her success story. So, they saved me from my life when I did too much drugs and went into seizures, and they did not ignore me when I was crying. They helped me get into detox. They listened to me. I relapsed and they did not